Hello, my name is Jamie Pank from Larry Children's Hospital, and I'm going to talk to you about low cardiac output syndrome in the CICU. We'll kind of go through this quickly, and especially for the slides that maybe speak for themselves, and try and focus on a couple of points, and then be able to explore those later. So our objectives are to understand the causes of low cardiac output syndrome after surgery, which is very common, especially for neonates. We want to identify and evaluate markers of LCOS, which is often conflicting. And then we'll leave reviewing specific cases for our live lecture. So the first thing I want to show is the typical swoon that I'm sure you've heard of. And this was from Warnowski back in 95, but this is a very typical chart showing decreased cardiac output 6 to 12 hours post-surgery. Now, in the modern era, with better bypass techniques, you see less of this, but we do kind of follow this swoon where we think the catecholamines sort of wash out and you're left with some myocardial depression. We'll talk about why that is. But even though that's improved in general, I think you still see quite a bit of it in the neonatal population because inflammation and injury is much more common. For low cardiac output syndrome, if you see it, you need to think of causes. So residual lesions, myocardial dysfunction. If you're talking about univentricular anatomy, the balance between systemic blood flow and pulmonary blood flow, abnormal rhythms like jet or heart block, and pulmonary hypertension, which is particularly a problem in neonates. You can also get diastolic dysfunction. This slide describes the patients after TET repair where you commonly have RV diastolic dysfunction. Very hard to see on echo, especially in neonates. And these patients had normal function, but you can see that the ones that had restrictive physiology or diastolic dysfunction had lower systolic blood pressure, less urine output, and a much longer length of stay. So you just have to be aware of which patients you think are going to be at risk for diastolic dysfunction. So there are a number of things that we do. This is more for a lot of times for the cardiologists and surgeons to talk about preserving or preventing low cardiac output syndrome. And then some of the things like homeostasis, making sure the rhythm is normal, balancing circulation, using ventilation and vasoactive agents in the CICU. We don't talk a lot about this, but some of the mechanisms for this dysfunction and low cardiac output is ischemia, reperfusion, ventriculotomies cause direct myocardial injury, and a lot of cardiopulmonary bypass-induced inflammation. That's often from exposure to the circuit. And one of the things I want to make sure that the terms are clear when we talk about bypass. So that's when you're mechanically circulating oxygenated blood for the body and you bypass the heart and lungs. But the heart is still beating. Whereas cross-clamp time, you'll often get both times when you're taking back a surgical case, is when the aorta is cross-clamped and the coronary arteries are no longer perfusing the myocardium. Usually you're using plegia to actually arrest the heart during that time. And the cross-clamp time for me is probably the more important one. But there has been less of an association between these times and low cardiac output syndrome afterwards, but still a really long time does get your attention. These are some of the cascades that causes inflammation and injures the myocardium and also causes third spacing. There are a number of different ways that people try and ameliorate this. One of them is steroids, which is still pretty common, or is pretty common after or during neonatal surgery. You might hear people talk about MUF, modified ultrafiltration. What this does is it concentrates afterwards and sort of dries the patient up. You reduce postoperative edema. There's less postoperative bleeding. You can reduce the inflammatory cytokines and endothelin levels. You see improved myocardial function and improved pulmonary function as you dry people up. This is very institution dependent. Some surgeons will do a lot of MUF and come out very dry. Other places will be a little more quote unquote wet. And that is something that's important to know about your individual institution. This is just talking about some of the things we just talked about, some of the improvements that you see with MUF. Corticosteroids, like I mentioned, obviously causes anti-inflammatory state, decreases vasoconstriction on bypass and increases perfusion flow, may have some neuroprotection, commonly used with neonatal surgery. You might have kids come out with delayed sternal closure. I'd say this is more common in the neonatal population where you have less real estate to work with. And so if they're having trouble coming off bypass or they expect a lot of swelling, this can prevent the cardiac compression that comes with leaving the sternum closed. Increases ventricular compliance and filling, decreases the pulmonary venous pressure, so it augments venous return, and this all improves cardiac output. You can have access for persistent bleeding and mitigates the adverse effects of especially high pressure, positive pressure ventilation. Now, this is kind of important, especially because delayed sternal closure is more common in neonates, is in the ICU is often where you're going to come and put the sternum back together. And what you want to watch out for, or the changes that you can expect if you do this a little early, you're going to see more of these. And there is a benefit to trying to get the sternum closed early as far as sedation, length of stay, and infection risk. But if you do it too early, you're going to see some hemodynamic consequences. So increased RA and LA pressures. You can see an increased heart rate as you may decrease your cardiac output. Oftentimes you'll need to increase inotropic requirement. As the intensivist, you need to be aware of the possible need for that. Your ventilation is going to be a little less easy, so PIPs need to increase a little bit and sometimes increase in FiO2. If you do this really late, you may see none of these changes, but the trade-off there is, again, infection. We've kind of talked a little bit about these sort of things, so kind of going along the lines of what are you doing to prevent LCOS or the crash in the ICU. So you're making sure you have synchrony, adequate preload. You're trying to balance pulmonary and systemic blood flow. We'll talk a little bit about pharmacology. And then you hear the words DO2 and VO2, so delivered oxygen versus consumed oxygen. I think pressure is important, but more important in the cardiac care unit is oxygen delivery, balancing oxygen delivery and consumption, meaning that you're getting enough oxygen to the patient's cells so that they're not becoming anaerobic. So you'll hear these words a lot. And how do we measure this? Basically, inadequate DO2 is low cardiac output, unless you have very high VO2. But the ways we deal with that typically is working on the delivery side. And if you can't get any more delivery of oxygen, then sometimes you need to try and decrease the VO2. So intubation, paralysis, sedation are all things that would decrease your VO2. So looking to see if it's adequate, one of the things we use a lot is NIRS, which I think you're probably familiar with, but it is a combination of venous and arterial saturations for the couple centimeters from the probe. Another thing you may have at your institution could have ediometry, could have sick bay, could have other monitoring systems. I think these are very helpful because they put trends up where you can measure things over time and look and see, for instance, in this scenario, we have SATs that are a little bit lower at the same time that our heart rate is going up. And then you can see our map is relatively unaffected. We use ST segments at Lurie, so you might see some ST segment elevation or depression if you're having myocardial strain. Very, very useful to track the progress of the patient and anticipate problems if you're trending in the wrong direction. Now, here is the tough part about low cardiac output syndrome. There are lots of signs that we use to look for it, but they're almost never all pointing in the same direction. And so there's a lot of clinical judgment to try and figure out, is this kid in low cardiac output syndrome? And certain people put different weights on different things. I like to use AVO2 difference quite a bit as sort of a gold standard. I think color and distal perfusion can be especially difficult in neonates who tend to have cool extremities even when things are fine, but sometimes they're not fine. So I think using some of these things in combination is important, and we can talk a little bit about those in the case examples. This is just kind of an illustration of, you might say something like, I think this child's in low cardiac output syndrome because we have depressed NIRS, high heart rate, and low urine output. And that patient may at the same time have a normal blood pressure and a low lactate or something like that. So if you do find yourself in low cardiac output, you want to look for anatomic causes uh, with the echo. Um, you can use your intracardiac lines, looking at things like CVP, MAP, stuff like that. If you do have residual lesions, there is decreased survival. So you do have to make sure that that's not what you're dealing with. Ventilation is something else that we use to treat low cardiac output syndrome. It reduces afterload, but it also decreases preload and it improves systemic oxygen delivery. You may already be familiar with this, but and we can go over this more in person. But basically, the myocardial wall stress is decreased when you have positive pressure ventilation, which causes less work for the heart to generate the same systolic blood pressure. There are questions about that we can go over in person. Um, so kind of talked about this with QPQS. Now you're not just talking about DO2 and VO2. Now the DO2 portion is going to be your QS. So if you have excessive QP, that might be stealing from your systemic output or QS. And one of the important things to know about that is illustrated on this slide. This is a measure of oxygen delivery on the lower one is for a patient with less contractility or lower cardiac output. And in that situation, your QP to QS has to be really optimal in order to have an adequate oxygen delivery to the body. Whereas if you have plenty of perfusion, good contractility, you can be very overcirculated or undercirculated, and you're still going to have enough oxygen delivery to the body. So trying to optimize your cardiac output will give you a much wider range to have various different QPQSs. You're still going to have enough QS. This slide is talking a little bit about oxygen delivery, and the idea being that if you're causing overcirculation, so for instance, the top slide is looking at QPQS. When you're 100% oxygen, you're going to have a very high QPQS, and it's going to decrease as you use less oxygen. So you think, okay, I want to just use the minimum amount of oxygen, but you also have to consider your arterial sat is also important in how much oxygen delivery. So in this model, which was a single V model, they found giving some oxygen actually helped because even though you sacrifice a little QPQS, you improve your arterial sat. And so the delivered sat is actually highest with a little bit of oxygen. That's different with different patients and different amounts of QPQS, but it's just to say that using the minimum amount of oxygen or minimizing QPQS isn't always the best strategy to ensure a good DO2. We also use a lot of vasoactive medications. Catecholamines tend to act on cyclic AMP, increasing cyclic AMP. Phosphodiesterase 3 inhibitors like milrinone decrease the degradation of cyclic AMP. So they go about it in different ways, but both of them use cyclic AMP to increase inotropy. I'm going to assume you guys know what milrinone does. It basically decreases afterload, increases inotropy, and it doesn't increase myocardial oxygen consumption, so it's particularly good on the heart. Relatively few adverse events. You can have arrhythmia, but fairly low risk. Hypotension is mostly during bolus doses. So if you can augment your cardiac output, milrinone doesn't tend to cause hypotension because even though you're decreasing SVR, you're increasing cardiac output and it tends to even out. One of the very few studies using different inotropes. I don't know if it's very few anymore, but one of the original ones was the Primacore study, found that using prophylactic milrinone decreased the incidence of low cardiac output syndrome. You can see here that the placebo had 27% incidence, high dose milrinone was 10%. I do like to show this where at the beginning with bolus doses, there was a decrease in blood pressure with milrinone, and that all evened out with the infusion so that patients had the same blood pressure on the infusions as placebo. And that just goes to show that if you have an adequate cardiac output, or if you're able to augment your cardiac output, your blood pressure should be relatively unaffected by milrinone. Catecholamines increase contractility and chronotropy. And there's a lot we could say about the different ones and different ways they affect you, and maybe that's something we can talk about in person, but we generally try and increase our cardiac output and raise blood pressure. Sometimes we use them in combination, but that may not always give you the effect you think it's going to have. I think patients' response to catecholamines is a little bit individual. And we try and use them sparingly because they may do more harm than good. This is an interesting slide. It's from the same univentricular pig model that I mentioned before, and it was showing that change in cardiac output with different levels of dobutamine and dopamine and epi. The dobutamine one's especially interesting, where it might not increase your cardiac output that much, even though most of the time it should. This is also using, you have to take into consideration QP and QS. But anyway, so potential adverse events for catecholamines is increased myocardial oxygen consumption. So it's making the heart work harder. You increase your afterload. You can have adverse effects on systemic versus pulmonary blood flow. So you have to titrate your, or at least choose your inotrope based on your anatomy. You can increase diastolic filling pressure with catecholamines, so decreasing your venous return. They're pro-arrhythmic, and you eventually do get downregulation of the cardiac beta-adrenergic receptors. Long-term use is associated with increased mortality. Combinations can be synergistic or antagonistic. So there was this interesting study where they combined dobutamine and epi, thinking, I think we always think of it as like, okay, I'm on epi at 0.05, now I'm adding 10 of dobutamine and my cardiac output's going to increase quite a bit. But in some cases you may not. Maybe that's because of competition for beta-adrenergic receptors, but they're not always additive. And some well-intended results, for instance, in this study by Hayes, found that goal-directed inotropy with dobutamine post-cardiac surgery actually increased mortality, presumably because we were making a post-operative heart work harder. So letting people have a little bit of low cardiac output at the cost of less inotropy may be beneficial. There are other adverse effects such as apoptosis. Dobutamine increases myocardial oxygen consumption even more than some of the other ones. So that's something that I think is still used more in NICUs, but we've largely gotten away from that drug in CICUs. So catecholamines are a necessary evil. They do improve hemodynamics, but you have a lot of potential adverse effects, short and long term. So I would say use them sparingly, use enough, but no more, kind of. Okay, there are a couple case examples we can go over in the lecture, but basically we want to focus on trying to identify low cardiac output when it's present, which can be confusing given that there are often 15 ways to measure it, and not all 15 are going to point you in the same direction. We do want to, if you are having low cardiac output, you want to exclude residual lesions. You've got to think beyond systolic function and increasing contractility, focusing also on preload, afterload, and balancing pulmonary and systemic circulations. And you want to optimize AV synchrony and cardiopulmonary interactions. So I look forward to seeing you guys, and I think that will be it.